The development of this podcast was sponsored by Alexion Pharmaceuticals Incorporated. The viewpoints expressed are those of the person speaking and not of Alexion. Welcome to NMOSD Your Way Global, an educational podcast series for NMOSD patients worldwide. NMOSD stands for neuromyelitis optica spectrum disorder, a rare relapsing autoimmune disorder of the central nervous system which primarily affects the optic nerves and the spinal cord. Your podcast hosts Lelainia Lloyd and Devic, who have both lived with NMOSD for over 10 years, will be bringing their respective Canadian and Australian perspectives to the table in order to help patients worldwide better understand NMOSD. Over the next 16 episodes, clinicians, researchers, and fellow patients will come together to have important conversations about how to live your best life within your diagnosis. They will be offering up encouragement and practical tips for overall health and well-being. In this episode, Dr. Daniel Selchen, a neurologist and senior consultant at the MS Clinic at St. Michael's Hospital in Toronto, Canada, clarifies the main differences between multiple sclerosis and neuromyelitis optica. He explains the importance of receiving a correct diagnosis and sheds light on the advancement of care and treatment for NMO patients. So, let's get started.
To begin with, Dr. Selchen, would you please explain what the main difference between multiple sclerosis and neuromyelitis optica are?
Thank you, Lelainia. That's a great question. They're really two different diseases. This has an interesting history. For many, many years, it was thought that they were very close cousins. NMO was called Devic's disease, and it was thought to be a variant of MS. So what has emerged in the last 15 years is that NMO is an antibody-mediated disease with a very specific antibody that's pathogenic. And MS, we don't know what the cause is. So it appears that they're actually completely different diseases that share some similarities. So the similarity is demyelination in the central nervous system, but they're really totally different diseases, and that's actually quite important to know.
And why is it so important that somebody get a correct diagnosis?
It's important because the treatment in general is completely different. And some of the treatments for MS can actually make NMO worse.
Yeah, there's been a lot of updates in what types of drugs are now available for NMO patients.
Absolutely.
It's great to have those options now. How accurate is the test for NMO?
So the blood test, testing for the aquaporin 4 antibody is very accurate. It's both sensitive and specific. So if you have a positive antibody, now there's no such thing as a test that doesn't have false positives and false negatives, unfortunately. But in general, if done in a good lab, the test is very good and very specific.
Okay, I ask because I was one of those patients that had that testing early on when the test was about only 2 years old and not available in Canada. And so the blood was sent to Mayo Clinic. And at that time, they didn't know about the false negative. And so I subsequently went on to be diagnosed as an MS patient because I had tested seronegative. And going forward, I've had probably close to a dozen tests run in all over the world. I think some of my blood was sent to Japan, some of it went to Calgary, Mayo Clinic got some more of it. And continuously I have tested negative. Do you find that patients who have tested seronegative remain seronegative, or do they at some point test positive?
It can vary a lot with aquaporin 4. People will sometimes test strongly positive during an attack. And when they're the same person, when they're in remission, may test negative. So if you have a very high clinical index of suspicion for NMO, we generally retest multiple times. And then there is a category of patients with what's called NMOSD, NMO spectrum disorder. So that includes patients who are persistently negative. And it's interesting because it's probably the ones who are aquaporin 4 who are antibody negative probably have more than one thing. There are probably a number of different disease categories falling within that entity.
Yeah, that's really interesting. And I think too, it's important for people to know that you can continuously test negative, but the diagnostic criteria also has been changed to make it easier to diagnose those of us who test negative. Can you just comment a little bit about what that looks like?
The criteria are different for people who are aquaporin 4 positive and people who are aquaporin 4 negative. If you're aquaporin 4 positive, you really need only one characteristic syndrome. Whereas if you're aquaporin 4 negative, you need at least two. The criteria themselves are actually quite complicated, but they're actually very useful, unlike some criteria that we use in medicine. These are actually quite useful and have been very well developed. But it's much easier to sort out people who are antibody positive because you don't need as much evidence to make a diagnosis. It's also really important because the new drugs are really pretty much restricted to people who are aquaporin 4 positive because the clinical trials were done in patients who were aquaporin 4 positive.
Yeah. So can a patient have both NMO and MS? Is that possible?
Probably no. I don't think there's any description of anybody who clearly has. Now, the complication is people can be thought to have MS before a diagnosis of NMO is made. But I'm not aware of the two diseases coexisting.
Yeah, because I hear a lot of people, in our community when they're first diagnosed and they're learning about, their disease, that they'll say, oh, well, my neurologist told me I have MS and NMO. And, in our community, those of us who have been diagnosed for a long time are like, well, our understanding is that those don't coexist together.
Yeah, your understanding is correct.
Yeah, it's good to have that clarified because, there's misinformation floating around out there. And it's always good to have, a neurologist say, like, no, that doesn't happen. So if a patient believes that they've been misdiagnosed, what can they do to advocate for themselves?
They can get another opinion. If they haven't been antibody tested, if they have characteristic symptoms. So NMO classically, the major symptomatology is in the eye and in the spinal cord. So if people have had recurrent episodes of optic neuritis and spinal cord episodes, then if they haven't been antibody tested, they should be. So antibody testing, and sometimes just getting another opinion.
So how does NMO affect a patient's quality of life?
Depends on the nature of the relapses. So NMO, more than MS, is a relapse-driven disease. So MS, it's very common for people to get worse without relapses. In NMO, most of the disability associated with the disease is specifically related to relapses. So it depends on the severity of the relapses. The problem is that the kinds of clinical syndromes tend to be worse in NMO. So optic neuritis, so transient loss or partial loss or loss of vision in one eye, is characteristic of these disorders. But in MS, the recovery rate is much, much higher. And with NMO, the likelihood of having severe visual impairment is much higher. Similarly, with spinal cord episodes, the recovery rate in MS is much better. NMO, people are much more likely to have mobility issues early on because if you're unlucky, it can only take one relapse, one attack to leave you with very significant problems. That's why, as you were alluding to earlier, Lelainia, it's very important to make the diagnosis because the consequences of further attacks can be really devastating. So it's really important to make a diagnosis of NMO and get people on the appropriate treatments.
Yeah, my experience has been that it hits very hard and very fast. And I treat it like a medical emergency. When I have even just the slightest hint of it happening, I'm immediately on the phone to my neurologist and acting as swiftly as possible. Sometimes, that gets challenged by having to go to the emergency room where they don't know me. And, I'm telling them, here's what's happening to me. I'm rare. Here's what the protocol is. And I get some pushback on that because, of course, I'm a patient and I'm telling them what their job is. However, for me, it's time is myelin and everything else and axons and, my ability to see and my ability to walk. And I take it very seriously because I don't want to end up with damage that we can't reverse. So
You're absolutely right. What I tell my patients, especially aquaporin 4 positive NMO patients, I tell them if they think there's something going on and they can't get hold of us, to come to our emergency room, where there'll be a record of their disease and where people are somewhat more familiar because we're a hospital that sees so much white matter disease.
right.
So I actually tell them, even if they live fairly far away, to try to come to our place because they're more likely. Time is important, and there's good evidence that for NMO related attacks, the earlier the treatment is initiated for an attack, the more likely you are. It doesn't guarantee anything, but the earlier the treatment is initiated, the more likely you are to have a good outcome.
Right. So when I was being diagnosed quite a few years ago, if you Googled NMO, you saw that all of the information that was out there on the internet basically said, well, you've got 5 years to live. And that's terrifying for people to come across. Fortunately, the information has much improved since then, although I'm sure that there are people still finding that particular piece of information out there. I wondered if you could talk a little bit about what the life expectancy of someone with NMO actually is.
Again, it's very much dependent on the nature of relapses and the effects of treatment. Because like MS, people don't die of NMO and people don't die of MS. What they die of are the complications of being immobile. So they die of infections, they die of pneumonia, of urinary tract infections, of aspiration, of swallowing issues.
Yeah, I know that there are a number of NMO patients just in my immediate circle who've really struggled with sepsis. Some of them, that's been a result of having paralysis and getting urinary tract infections that they may or may not recognize because of a lack of sensation. So, it's definitely something that we have to be aware of and keep our eye on. And again, react swiftly if we suspect that we're not feeling well and it could be an infection. I know I've had episodes where I've spiked a fever for nothing that I can discern, nothing that seems obvious, and gone in and, had to be tested to make sure that it's not something that's going to kill me.
So I think that's a very individual issue. In the context of a pandemic, it makes sense for people who are at all immunocompromised to be very cautious about where they go, to follow all public health precautions, to make sure that everybody around them is masking if in the appropriate context, and just to be sensible.
Yeah. And I know for myself that I talk to my friends and family about getting a flu vaccine because, it's sometimes the simplest things that can really affect us and make us super sick, and things that other people can, sort of shrug off, with basic treatment could become dire for people with NMO. So that's one way that and I say to people when they're coming to my home, please don't come if you're not feeling well, because, that little bug for you could turn into a major thing for me. So It's always good for the people in your lives to be aware of that and just kind of think about that a little more carefully when they're thinking about spending time with me. So, Dr. Selchen, was there anything that I didn't ask that you were hoping that I would, that you think that NMO patients and their caregivers should know about NMO?
I think you did a pretty thorough job. I think if I was going to give a final message in this regard, it would be that there's probably an advantage if you have a condition like NMO to be seen in a multidisciplinary facility. So a facility where you have neurological knowledge, you have access to a urologist, sometimes access to a psychiatrist, to a physiatrist, to physios and OTs and social workers. So I think now, obviously, these kinds of facilities aren't available to everybody, but I think there's a strong argument for trying to consolidate treatment in as to consolidate in as limited a space as possible so that people can get benefit from multidisciplinary care.
I agree. Some of the clinics for MS where they see NMO patients have what I think of as collaborative care. And I think that it's really helpful to be in a setting where everybody's on the same page. They see your record, they know your story, they understand your disease. So whether you're seeing your neurologist or your physiotherapist or, the physiatrist, the pain and rehab specialist, they all know your story and they all understand what needs to happen, and they're working in concert with one another, because it's really hard as a patient to be seen in more than one healthcare catchment area or at different centers. Like you might go to, say, an endocrinologist to see about things that affect one part of your body. And then the next day you're going in another part of the city to see another one. And there's it's really hard to have communication between a bunch of specialists when they're all in a different setting. And it's really hard on the patient to have to go chasing around to get kind of what I think of as piecemeal care. I mean, you're getting care, but it's in a sense that it's broken up over a bunch of places. So yeah, if you have access to a setting where it's all collaborative care and everybody you need is there, it makes a huge difference to your coping for sure. So finally, I just wanted to ask, when you're working with NMO patients and you've seen the damage that this disease can do and how it changes patients' lives, what gives you hope and inspires you to continue the important work that you're doing?
Well, I've been doing this a long time. So when I started practicing in this area, there were no drugs for MS or what we call Devics at that point. There were no MRIs, and bad disease, be it MS or NMO, was really, really bad. So what inspires me is that we've now got good diagnostic tests. The antibody testing is only less than 15 years old. MRI is 30 years old. So we've made tremendous advances in diagnosis because we're able to really identify NMO much earlier now than we could in the past. I'm also in both of these therapeutic areas because the same thing has happened in both MS and NMO. So we now have targeted drugs for treating bad disease, which even a few years ago, even 10 years ago, we didn't have for either disease. So we now have agents that are much more effective. So I think the future for people with these diagnoses is much brighter because they'll, God willing, get diagnosed earlier. And if they need it, treated more aggressively with more effective therapies. So I'm very hopeful that we're going to see now and in the near future significantly better outcomes for people with NMO because of the tremendous advances in the last few years in both diagnosis and treatment.
I agree. And I really feel that, the ability for us to now have new therapies for some of us who've cycled through some of the old ones and have not had them work as effectively as we might have hoped, the ability to have the access to those new therapies, it gives us somewhere to go if we like in terms of treatment, but and that is a huge thing that allows us to have hope. I think, when you get to all of the end of all of the treatment that's available and you feel like, oh my gosh, what am I going to do if I fail on another drug? And I always, I have to think of it differently, because it's not a matter of the patient failing the drug, it's the drug failing the patient. And so, when I look at that and I think like, at least now we have these therapies, we have somewhere to go with this. And that alone gives us so much hope. And I think, even for neurologists, because, there must be times where you're feeling like, oh my gosh, I've done everything I can for this patient and it's still not enough. And, I understand how that will give you hope too. And I really, really appreciate your time in speaking with us about this important topic. I think it's so important, not just for patients, but also for other healthcare providers to understand the difference between these two vastly different diseases. There's so many symptoms that are common, but the treatments and, just how it affects each person is so different from one another, the MS to the NMO. So thank you so much, Dr. Selchen.
We hope you have enjoyed listening to this NMOSD Your Way Global podcast. For more information about NMOSD and access to support and resources, please read the podcast description. What you have heard in this podcast may not be reflective of your own experience and does not replace the advice of a healthcare professional. If you have any concerns or specific questions about NMOSD, please speak to your physician.